It gives me great pleasure to introduce Dr. Nora Jaskowiak. She's a general surgeon here at the University of Chicago. She did her, actually, I don't know where you did your undergraduate studies.
At Harvard.
Oh, at Harvard. Okay. And then also medical school at Harvard, and then did her residency at the University of California, San Francisco, and then did a fellowship here at the University of Chicago. She is the, I believe, director of the breast surgery program. Sorry, I'm just looking at your bio. And an extremely busy surgeon, does tons of breast cancer surgery, and is a top-notch surgeon as well. And so she's going to talk to us today about her experience as a surgeon. And interestingly, I'm just seeing your bio that actually you did research with Dr. Wexelbaum, who they heard from a couple weeks ago. So you can see it all kind of ties together in oncology. Mm-hmm. But with that, I'll turn it over to you. So let me just stop sharing my screen. You should be able to share your screen now.
All right, hold on. Let's see if I can make this work. Okay. Great. You guys can see?
Yep.
All right, good. So thanks, everyone. I'm sorry that I can't see more of you, but I'm going to put on my little side viewer there so I can at least see some of you. And Dr. Golden and Dr. Hahn have heard this talk over the last few years because it doesn't change too much. So, so hopefully they'll find something interesting in it, and hopefully you all will also. What I thought I'd start out talking about is, oh, I got to figure out, here we go. Is just a little bit about my story. Obviously you got a little bit from Dr. Golden, but my history is I grew up in Chicago. I grew up on the north side of Chicago, and then somewhere in after I figured out I couldn't be a priest, which was my original plan, I decided that I would be a doctor, and decided that early on, probably related to the fact that my mom had breast cancer when I was in 7th grade, and I had been named after my grandmother, who died of breast cancer a few weeks before I was born. But who knows? Anyway, I always say it's because I like science and I like people, and so therefore that I should go into medicine. So decided on that. When in high school, I came very close to going to the 6-year medical program that was at Northwestern at the time. And then a wonderful man who's a surgeon, an ear, nose, and throat surgeon, who was a friend of my uncle's and whose daughters went to the same high school that I went to, just took an interest in me and invited me to spend some time with him, and basically kind of convinced me, like, you know, you're going to get into medical school someday and you'll eventually work out about paying for it all someday. So don't try to take a shortcut. So then I went to Harvard for undergrad, and had a wonderful experience there, and then stayed there for medical school. And when I entered medical school, I had thought I was either going to be a pediatrician or a neurologist. And these kinds of things I think are because I love kids and I love the brain, and so that just sort of seemed. But then I sort of quickly figured out that I really also love anatomy, and I also really love doing things. And so whereas pediatricians are great and so are neurologists, but they don't get to do that much. And so quickly, as soon as I was on my rotations as a 3rd year, figured out that some kind of surgery would be the right thing for me. So then I kind of searched out and looked at general surgery. And it's under all of this was always this vibe about cancer, that I wanted to be involved in the care of cancer also. And so I looked at general surgery and ear, nose, and throat surgery and gynecologic oncology, and ultimately decided I would do general surgery with a pathway towards some kind of surgical oncology. And so then I was really fortunate to match at UCSF, and that was great. And then I had amazing mentors who, interestingly, a lot of my one of my major mentors as a resident was a senior resident, a terrific guy named Jerry Doherty, who now is the chair of surgery at the Brigham and Women's Hospital. And he was always committed to cancer, and picked up that that's what I was interested in, and he's and I are remain close to this day. And he encouraged me then in the middle of my residency to think about applying for a fellowship that existed at the National Cancer Institute, and that fellowship still exists, just like Dr. Fauci, who was there when I was there at the NCI, was the head of allergy and infectious disease at the time. So Dr. Rosenberg, Stephen Rosenberg, was the head of the surgical branch of the NCI, and so I got to go to the NCI for 2 years, and that was just awesome experience to spend 2 years in Bethesda, and doing both clinical research and bench research, and taking care of patients who came to Bethesda to be on various clinical trials that were there. And it was just an amazing 2 years. And then I went back to San Francisco and clearly committed to surgical oncology, and then finished my residency there. And then, this is where life kind of comes in, which always is part of it. So I had, by that point, married my college boyfriend, and he is from California, and obviously I'm from Chicago. And so when I was starting to look at fellowships, he kind of said the surgical residency at UCSF was super intense at that time. Of course, surgical residency is still very intense, but maybe multiply that by about 1.5 times when there were no hours restrictions or anything. And he basically said, okay, if you want to do more training, it has to be in Chicago or in Los Angeles. And so we looked at the fellowships, and clearly the University of Chicago fellowship was the best of all of them. And so then I was again super fortunate to be able to come to U of C. And the original plan was 3 years in Chicago, and then we would go back to California. But then, of course, life takes its course. And in this story, this part of the story, it was because my mom passed away completely suddenly. And it was great to be home, and for my dad and for all my siblings. And then, at some point you start to put down some roots, and we had our first child when I was a fellow. And then my husband's job was such that he really wanted to stay in Chicago. So then we stayed, and now we've been here for, 1998. So 22 years, I guess, this summer. And it's been great. So then I was, of course, wanting to stay at U of C to work, and initially they didn't have a job for me. And then just as luck would have it, about a week before I was going to sign a contract to be a breast surgeon at one of the big advocate hospitals out in the suburbs, then the head of the breast center, the surgical head of the breast center at that time, a great guy named Danny Takanishi, decided to return to Hawaii and become the chairman of surgery at the University of Hawaii. And so then rapidly, this is how things used to be. Maybe Dr. Golden and Dr. Hahn will appreciate this, that, by a few days later, I had a bunch of interviews, and about 2 days later, I had a job offer. And so then I stayed on, and then my first job, and still my job, is that I was the surgical head of the breast center. And so now I've been doing this for the last, almost 19 years, coming up soon. And then, you'll hear more as I talk about surgeons and cancer, but there's all kinds of, things that I've done, from obviously being incredibly committed to patient care, and I do like to be busy, and I like to do surgery. So that's been my main thrust. But I also have been involved in clinical research, as kind of collaboratively with the medical oncologist and the radiation oncologist. I worked with Dr. Wexelbaum in Dr. Wexelbaum's lab during my surgical oncology fellowship, and just had a great time doing work with the VEGF and radiation and anti-VEGF antibody and radiation, and it was terrific. But then that was really the end of my basic science research time, but have been collaboratively involved in research and also on big clinical trials. All right, so that's the Jaskowiak story. So now to kind of talk about surgery and cancer. You know, when you look back, you know, people have been doing things for the breast, you know, forever, because breast cancer has existed for as long as women lived long enough to develop breast cancers. And, you know, going way back, there, you know, was like cautery, like hot pokers to take care of fungating breast masses. And then there were kind of the barber surgeons of through the Middle Ages and up through the 1700s. And then things started to get a little more formal in the beginning of the 1800s. And then in the middle of the 1800s, there was two major breakthroughs in surgery. And that involved the development of anesthesia, which happened in the 1840s, and then the development and the maturation of germ theory with Louis Pasteur and Joseph Lister and Semmelweis, and the work that they all did to promote sterile technique and the understanding of germs and wound infections. And so, you know, if any of you have, it's closed right now, as all museums are closed, but I really want to make a call, a push that when things reopen, that everyone should take a trip to the International Museum of Surgical Sciences, which is on Lakeshore Drive, right on the Gold Coast there. You pass it every time you drive down North Lakeshore Drive. And it's an awesome museum that has a lot of amazing history. And they have this awesome room called like the Hall of the Greats or something that has statues of everyone, you know, going back to like Hippocrates, but then all these people who I love to talk about, like Lister and Pasteur and Semmelweis, and how they really helped bring surgery, you know, to full, you know, full practice, formal practice. And so then by the end of the 1800s, the early 1900s, surgeons were really starting to become much more formal. And then this was an era of radical surgery for cancer, right? So we didn't have it, chemo or radiation or endocrine therapy or targeted therapy or immunotherapy. And so surgery was it. And so there was a big, you know, you could just cut it out, and the more that you could possibly cut out, the better. And this got, you know, formalized for breast as well as for many other things. And then through, you know, the middle of the 1900s, we get adjuvant therapy of all sorts. And now we're in this amazing era of multi-modality care and neoadjuvant care. So, so it's really been an amazing development. Now, the thing I always like to say about breast cancer is that the care, I always think of breast cancer as the model of multidisciplinary care. So, and you would all be welcome, and you know, you can just, Dr. Hahn can tell you how, or you can just email me to know if you want to come to breast conference. And our breast conference now, of course, is on Zoom, and it's every Thursday morning at 7:30. And it's actually been pretty awesome of all the weird, good things about COVID that we have great attendance now because not everyone has to be in the hospital at 7:30 in the morning for breast conference. So so we have great attendance, and any of you could, I could send you the link to the Zoom call. And so at the conference, of course, there's surgeons. And when you think about who does breast cancer surgery, of course, general surgeons still do the most breast surgery overall, but surgical oncologists often do. And now, of course, there are many breast surgery fellowships. So those are kind of the all the surgeons involved, plus plastic surgery. Breast imagers, we really shouldn't call them mammographers anymore because they're doing all kinds of imaging. Medical oncologists, radiation oncologists, pathologists, nuclear medicine because of sentinel node biopsy, social workers, genetic counselors, and then of course all of our terrific support staffs, nurses and APNs and all the research assistants who attend conference. So it's a really great conference, and we talk about pre-op patients, and we talk about post-op patients, and we talk about patients who are causing us dilemmas in their decision making. So this is a slide that you'll see sometime, I hope, when I get back, when we all are teaching again and for CPP and T, what is kind of like that classic, how does a breast patient ever get, through the system? And so typically it starts with, someone either having an abnormal screener, like I said, no screening happening now, though officially the governor did say that screening could restart on May 1st. And so we are now at U of C open for screening again. And they're doing some, not the normal volumes, but some. Or else the patient has a complaint, right? They feel a mass, or they have some breast complaint, pain or discharge or something that draws their attention. And so then they usually end up these days having a diagnostic mammogram first, although sometimes they'll see a surgeon first about a complaint, and then everything then comes around to the diagnostic imaging, which is just incredibly important. And then pretty much everyone these days gets some kind of biopsy. And usually these days it's a needle biopsy, and usually these days it's a core needle biopsy, but sometimes surgery is needed to make a diagnosis or some other type of biopsy. Very often these days we add MRI into the mix. And then this is kind of, the usual way that for years and years, surgeons have always typically operated first. And then if the patient needed chemo, and then radiation, and then the anti-estrogen medicine. But of course, these days, all the time, we switch around the order. So all the time we move chemo to the front of the line. And quite often we move anti-estrogen medicine to the front of the line. And now, like in the era of COVID, we, especially when we weren't able to operate with ease, again, that's getting better, as you heard at the beginning, but that we have been using a lot of anti-estrogen medicine. Basically, pretty much every patient who's estrogen receptor positive, who we might have just operated on right away, we now are having on anti-estrogen medicine until we can safely take them to the operating room. So this is kind of how it goes, that comes through all of this and then gets into the whole treatment paradigm. But like I said, a lot of times these things happen out of order. All right, maybe I know that Dr. Golden said it's hard for you guys to just hear someone talk for a huge amount of time. So I'll just pause here for a second and just to see if anyone has any questions at this point. All right. Well, I'm looking down. I can't actually see the chat, but okay. So I'll just keep talking. So when you think about a surgeon and how can you be involved as a surgeon in cancer, and there's a bunch of different routes, right? So the route that I took is to become a general surgeon first, and that training right now is 5 years of general surgery residency. And then after that, you could do a fellowship, right? You could do surgical oncology fellowship, which now is a board certified, HCGME approved fellowship. There are breast fellowships. There are actually more breast fellowships available, like that in the United States right now, than there are actually formal Surg-Onc fellowships. That is not a certification, though. It's a 1-year fellowship, but you don't get a certificate. There are colorectal fellowships, and colorectally trained surgeons, take care of a lot of cancer, a lot of rectal cancer and a lot of colon cancer, and they're very involved with anal cancers also, but they also take care of like ulcerative colitis and diverticulitis and Crohn's disease. So that they have that sort of as it's part of their practice as well. And then of course thoracic surgeons, who take care of a lot of cancer and then also a lot of other benign thoracic conditions. But general surgery would be the route into all of these things. Separately, of course, ENT has all the head and neck cancers. Urology has a huge urologic oncology part of their field, and again, you would do a urology residency and then a urology fellowship. Then neurosurgery, there are people who do neurosurgery and then either can just go out and take care of cancers or do special fellowships. Gynecologic oncology is a fellowship that is done after an OB/GYN residency. And I think you probably might have heard from Nita Lee or will hear from Nita Lee, but in the old days, you could actually do a general surgery residency and then a gynonc fellowship, but someone put the kibosh on that route about 20 years ago. So now you have to do OB/GYN. And then ortho, you could do general orthopedic surgery training and then ortho oncology fellowships. So a lot of different ways to be involved with the care of cancer patients as a surgeon. And then separately, of course, I work regularly with plastic and reconstructive surgeons who are very involved in the care of cancer patients. And for breast, obviously doing reconstructions of the whole breast or partial breast. And then for lots of other cancers, we cancer surgeons cause a lot of holes in things or big empty spaces, and then we need plastic surgeons and reconstructive surgeons to fill up those spaces. And pediatric surgeons, take care of everything. They're like the last general surgeon just for kids, but they take care of their own cancer patients, doing sometimes quite dramatic cancer operations in all parts of the body, the chest and the abdomen principally. So, like I was saying, the role of surgeons has really evolved over the last, about 120 years. So originally when surgeons was the only game in town, then surgeons were really the kings or queens of cancer care. And they were the only thing we could do for cancer. And then as adjuvant therapies came along, chemo, really adjuvant chemo kind of starting in the 1960s, and then radiation, starting earlier than that, those things got added on. And now with targeted agents and endocrine therapies, and there's some people even do raise the question, what's the future of surgeons in the care of cancer as the systemic treatments become better and better. But I think there really will always be a care for cancer because if you can cut out a small cancer, sometimes that's easier on a patient than forever taking endocrine therapy. Or and then also similarly, a lot of times you get amazing responses from chemotherapy, but we still don't know for sure that all the cancer is dead just based on current imaging. And so surgery is always a part of it. And in fact, there was some really great recent work raising the question in breast cancer patients, could you just repeat a needle biopsy at the end of someone's upfront treatment? And if there was no cancer, then think about not operating. But 4 different recent studies all showed that right now imaging and needle biopsy combined are not good enough to predict that the patient has had a complete response to chemotherapy. So I think that we'll have a role still for a long time to come. All right, I'm going to take a little break here before I dive into anything further in case there's any questions right now.
Yeah, I had a question.
Terrific.
So I know that surgical innovation, is a thing. Surgeons innovate, and I was just wondering if there were any different approaches, especially in breast cancer surgery, that you were excited about or had been thinking about that we might not know of.
Right. Well, I think one of the things in breast cancer surgery change constantly, and I'm gonna in the next few slides I'll go through some of that. But of course we've innovated from doing big mastectomies to doing small lumpectomies, and now the next phase of that is going from just doing a lumpectomy and sort of saying, well, you should just be happy with however, shape your breast turns out, to doing what we call oncoplasty, which is where breast surgeons themselves, or sometimes breast surgeons and plastic surgeons together, try to optimize the cosmetic outcome, even when you're saving the breast. There have been huge innovations even in mastectomy and reconstruction, moving from skin, regular old, big old mastectomies to skin sparing mastectomies, and now nipple sparing mastectomies, and then all the reconstructive innovations that go along with that. The next phase of things, I think, really are the potential role of robotics for mastectomy. They're both in Asia and in Italy. A particular guy in Italy and a particular guy in France have really been spearheading the use of the robot for skin and nipple sparing mastectomies, and that just is starting to be looked at in the United States. And then I think also in the axilla, we've obviously made huge strides, obviously from the old days where we took all the nodes out to the sentinel node biopsy. But then even in patients like who present with involved lymph nodes, the standard up until a few years ago would have been, you still have to take out all the lymph nodes, even if they look like they have a great response to chemotherapy. And now we do this targeted axillary dissections. And then a lot of work going on with trying to minimize the morbidities of cancer surgery, breast surgery, in terms of trying to avoid lymphedema of the arm. And so both sentinel node biopsy and then another procedure that's called axillary reverse mapping are being employed to minimize the morbidities. So to me, in terms of like the new things that we're really working on now that are going to become, I hope, more standard, are the reverse mapping, and then potentially something called lymphovenous bypass that can be done. The increasing work on oncoplasty, the work on robotics, and then this, I think, real push to say like, okay, we gotta figure out some people who might be able to avoid surgery altogether. So I hope that answers your question. Great.
That was great.
All right, any other questions? All right, so now we'll kind of walk through all this. So when we think about breast cancer, like I said, it used to be this big radical mastectomy. So people talk about Halsted and the radical mastectomy. And then we kind of, we'll talk about the cooperative group trials and less surgery for the breast and less surgery for the axilla. I have to throw, right, to entertain you with a few mammograms. So this is an innovation that has come out in the last few years in breast imaging, which is digital mammography. So whereas all the films, like when I started practicing a few years ago, everything was on film, and now everything is digital. And digital mammography has all kinds of benefits in terms of reducing the number of actual images that you have to take, because you can play around with the contrast and magnification on the image itself instead of having to, literally, we used to put kind of magnifying glasses between the beam and the breast in order to magnify things. Ultrasound has a huge role in the care of breast cancer, and these are some malignant masses, which you can see because they're kind of crazy looking and they're irregular and taller than they are wide. And now more and more breast surgeons actually become certified, as both Dr. Bao and I are certified in breast ultrasound, so that we can do our own ultrasounds and even our own ultrasound guided procedures. So ultrasound's really been awesome, and is like basically, I think of it as like the stethoscope of the breast, because that you can feel things and then you can just put an ultrasound on it and actually see it. This slide is the kind of a classic slide from one of the cooperative groups, this amazing group that's called the Early Breast Cancer Trialist Collaborative Group. So it brought together all the data from 6 different randomized trials that looked at partial mastectomies or lumpectomies, and then looking if you didn't radiate versus if you did radiate, and then looking, at the 20-year numbers and seeing how radiation, immensely decreased the chance of local recurrence in patients who save their breast. Just to kind of give you a little bit idea when I'm talking about surgery, this would be like your classic mastectomy, right? Like old-fashioned mastectomy. So we would just make a big elliptical incision, kind of take as much skin as you could, take the nipple and the areola and any incisions that were on the skin, and then you raise up these skin flaps off of the breast itself, going all the way to the clavicle and the sternum and down below the fold and out to the latissimus dorsi muscle and over the whole entire axilla to expose the whole entire breast. And nowadays we do skin sparing. So skin sparing, initially we would make this circular incision and then a little extension. Very quickly we dropped the extension and then basically did the whole mastectomy through just this round incision. But nowadays, we all the time spare the nipple. And so when we spare the nipple, we'll either just make a radial incision, but much more commonly, we actually make the incision down in the fold, which then we basically do the whole entire mastectomy from the bottom up. And that operation is a beautiful operation for the patient. It's a beautiful end result because you basically don't have a visible scar on the skin at all. And again, everything I love the innovation question because we were just talking about this in clinic yesterday. Like I always, when I do fold incisions, I always used to make a separate little incision in the underarm to do the sentinel node biopsy through. But now, by just pushing myself, if I instead of making the fold incision in the center of the fold, if I kind of just take it a little lateral, then I can actually do the sentinel node biopsy through that incision and avoid any incision in the underarm. So we're constantly pushing. The thing about this fold incision, as beautiful as it is for the patient, it's really, really hard operation as a surgeon because you have to take so much care in keeping the skin alive and keeping the nipple, enough blood supply to the nipple. And literally for the first part of the operation, you're like working uphill till you get, over the top of the mound of the breast, and then you work downhill from there. But then you got to get all the way to the clavicle. So you're down here and you got to get up here. And it's very, kind of literally sort of backbreaking. A lot of breast surgeons are developing neck and shoulder problems. And so that's one of the things that's really pushing people towards the use of the robot, because when you use the robot, you just get to sit at the robot and sit at a console and have the whole operation done while sitting down. So that's there's been a ton of evolution there. And then again, in the underarm, in the old days, the Piratical surgery would go and take all 3 levels of lymph nodes, level 1, level 2, and level 3, strip all this stuff out. And it was a great way to see if there was tumor in lymph nodes and a great way to, have local control, but it was also a great way to cause trouble for people because when you strip all that stuff out, you inevitably interrupt some of the lymph drainage of the arm, leading to lifelong and life-altering lymphedema. Here you see in the axilla, here's the vein and the arteries behind that and the important nerves that we have to save, the long thoracic and the thoracodorsal, but you go up under the muscle and strip everything off and you see like how well you see the vein, like we just strip all that stuff off the vein, everything coming out. And again, that's great, except it doesn't change people's survival and it can hurt them a lot. And so that's where this whole idea of the sentinel node biopsy has come from, right? That lymph from the primary tumor, drains preferentially we always call it a sentinel node biopsy, but in fact, it's generally like 2 or 3 nodes per case, but sometimes 1. And then they figured out that if any tumor has gotten to the basin, it goes to this node before going to other nodes. And so if you can check out that node, that you could potentially avoid a dissection. And then that's been carried on now, right? So say, okay, well, if that node's negative, we don't have to take the rest. And then brought to the point, okay, well, if that node or nodes just has a little bit of tumor in it, but not a lot, you could leave the rest of the nodes because chemo and radiation and anti-estrogen medicine will take care of the cancer. And now we even say, like, okay, if a patient presents to us with this node involved, grossly involved with tumor, but if we can kill it all with upfront chemotherapy, then maybe we don't have to take out the rest of the nodes and spare people, unnecessary morbidity. So I like to pivot at this point just to talk about, I know you guys are doing research, so what are the research opportunities for surgeons? And I think there's all kinds of research opportunities, and everyone finds, what's right for them. But of course, there's basic science. There are still surgeons who, operate basic science labs, usually not, independently, but usually within close collaboration, with the PhD, but there are surgeons who are leaders of labs or who work very, very closely, translationally. Of course, can be involvement in group trials. So groups like the Alliance and what's called NRG that need surgeons, right? Because if you don't have a surgeon who generally sees the patient first, say, oh, you could go on a trial, or the surgeon who makes an amazing relationship with the patient to encourage people to go on trials is really a great way to be involved in research. Investigator-initiated trials are definitely the case, right? So every idea has to start, with something, and so there's a lot of ability for surgeons to do small, local trials. And then surgeons and surgical oncologists are very involved these days in, outcomes, what's called, outcomes research from big databases and comparative effectiveness research. And lots of our surgical residents now will do this master's in public health research to get all the statistical methods down and learn how to use the statistics programs on these big databases like, SEAR and the National Cancer Database, the NCDB, to be able to, eke out data from big patient experiences. And then I think there's also great academic opportunities, right? So the IRB, lots of surgeons sit on the IRB and review protocols. For pretty much my entire time at U of C, I've been on this, what's called the CTRC, which is the Cancer Trials Review Committee. So every cancer trial before it goes to the IRB has to be reviewed by this group, and it meets monthly, and we all review protocols, and it's really amazing. For me, I learn something a lot every month, and I get to review protocols and critique them and say whether we think we should do them or not. There's academic opportunities in the cooperative groups, as you know, from Dr. Hahn and Dr. Fleming, Dr. Shimura, all at U of C, who have big roles in the various cooperative groups. There's great academic opportunities for surgeons who are involved in cancer in teaching, right? So teaching students and being program directors of residencies and being program directors of fellowships. And there's always like lots of wonderful teaching opportunities. And then there's also great academic opportunities to be involved in the various societies, like for surgeons like me, the Society of Surgical Oncology or the American Society of Breast Surgeons, to be involved on committees or in the leadership of those societies, or in ASCO. Also, even surgeons are involved in ASCO. So just to talk for a second about rewards, obviously, like I love what I do, and I really love caring for patients. For me, that's hugely rewarding. I really love my team, and like I have a strong bonds within my general surgery colleagues, but really the breast team, who I'm working with all the time, is really a team that I kind of think of as my own. And then the amazing thing about taking care of cancer and being a surgeon is that things constantly change. It's like an ever-changing thing. We just presented this morning a case but it wasn't really a complication, but kind of slight complication, interesting case at our M&M this morning morbidity and mortality rounds for general surgery. And I got like 3 different emails from colleagues saying like, oh my gosh, I didn't even know you guys were doing that. You know, like the only thing I know how to do with lymph nodes is take them all out, you know, versus kind of selectively removing lymph nodes, you know, that previously had tumor in them. So it's just continuous change. You have to keep up on everything all the time. As a surgeon, you have to know the drugs, right? And you have to know what the radiation oncologists are doing. And you got to know all this stuff. So it's super ever changing and really, really interesting. So this is just my summary that the care of breast cancer patients in 2020 is a multidisciplinary undertaking for which surgeons, you know, play a major role. We're advancing things all the time, improving survival and improving quality of life, but there's still a ton to do to decrease morbidity and mortality from breast cancer treatment and from breast cancer itself and breast cancer treatment. And so that's why it's, you know, if y'all become surgical oncologists, I think it would be awesome. So now that's it for me. Any questions?
Just looking at the chat box also, see if anybody, any questions from the group?
So of the surgeonc specialties, which ones blend like drug therapeutics and surgery the most? I know ENT probably falls into that, but are there any others?
Oh, I mean, I kind of think almost everything now, right? Like breast has been a huge leader in this, but if you kind of look at anything, right, that, you know, like gyn-onc, you know, huge. In fact, the gynecologic oncologists are the only surgeons who actually give the chemo themselves. They are all trained in their gyn-onc fellowships, not just in the surgical parts, but actually in chemotherapy administration. And they've held on to that very, very tightly. So, so gyn-onc is a huge example, but, you know, even things now like pancreas cancer, right? Where you'd think like, okay, well, if you have localized pancreas cancer, you know, patient's gonna get a pancreatectomy, get a Whipple or whatever. But now all the time, you know, there's evidence that neoadjuvant therapy, esophageal cancer, you know, same deal. So even, you know, the thoracic surgeons, and there's now studies, I think several studies have gone through that CTRC recently about neoadjuvant, you know, chemo for lung cancers. So, so every cancer, I think now, it has to be, you know, involved, you know, really that, I hate to say it, but like the only thing we don't really have good chemo for still, and Dr. Golden, Dr. Hahn could comment on this, but is sarcoma, right? Those sarcomas are, you know, soft tissue tumors. There's really not great chemotherapy. These are rare tumors, so they're hard to study, but they really so pretty much people who have a resectable sarcoma will have surgery, although there's some neoadjuvant therapy for that. So I would say whatever, if you become a surgeon, almost whatever you go into, maybe the last bastion, I'm just thinking thyroid, maybe, because, you know, most thyroid cancers are, you know, papillary cancers, medullary cancers, and follicular cancers that you generally will, you know, don't give chemotherapy for those. And so those people kind of are in their own little island. And there's actually been I think there's a ton to be done if anyone is interested in endocrine therapy. And I think moves are happening now in terms of trying to like formalize more randomized trials within endocrine, you know, thyroid and other endocrine things, because they've sort of avoided that. They've been maybe the one group that's really avoided it. So that's a great question.
Really interesting. Thank you.
Any other questions? I had a question oh, go ahead, Maria.
Hi, Dr. Jaskowiak. I was wondering, in addition to robotics, how do you think the field will change in the next 10 years by the time we start practicing?
Yeah, so I think that it'll start to get worked out better. Like, is there a protocol that can be done to figure out like who doesn't need surgery. So if you have, take people like who have triple negative tumors or like ER negative, PR negative, HER2 positive breast cancers, right? And it's actually sort of ironic. It's such an interesting question, but like in April, when Dr. Golden was asking me who did I get to operate in April, and there were all these triple negative cancers who had gotten neoadjuvant chemo and who were coming, just they were due for surgery and there's nothing else to do for them. So we had to operate. And like 3 of those people who I operated on in April all had complete pathologic responses. All their tumor was dead. So the people who actually have live cancer still in them, I'm having to delay because of COVID and put them on other therapies or kind of put them in the holding bin. And then these people now who've had awesome responses and don't actually have any living tumor in them are the ones who I got to operate on. But it's not there yet. But I think that there will become protocols, protocolized, like you have to do the biopsy with a big needle and you have to take so many specimens, and then how to follow those patients. But not everyone, I don't say this happily, but it's still pretty rare. Those there are groups of people who have a very high chance of having a pathologic complete response, like the triple negatives or the HER2 positives, but the vast majority of breast cancer patients are ER positive and PR positive, and at least right now they don't. And so so surgery will still happen for those people, but then we're getting better drugs on those people, like the CDK4/6 inhibitors. And so just, I think surgeons working with the medical oncology colleagues to sort out. Yeah. And then the other really interesting question is like who, we talk a lot about not doing surgery, but then there's women who are like, you're doing surgery on me. Like we had all these people who want both of their breasts removed, even when they have a tiny tumor. And so I think then having, figuring out how to optimize things for those patients. And like Dr. Stacy Lindau, who's so amazing, was doing this whole bionic breast project, right? Because I can do a beautiful skin and nipple sparing mastectomy, but it's insensate, right? The patient will have no sensation the vast majority of the time. And so maybe that's, the next thing to think about, like how do we possibly reinnervate, the skin. So there's a lot still to figure out, and there's still tons of room for innovation. Even like the calcifications, right? Like we'd have to do mastectomies on people who have 11 centimeters of calcifications, even if they look like they've had a complete response. Well, maybe we can start to figure out, with better imaging, who not necessarily, who doesn't necessarily need to have a mastectomy just because they have microcalcifications.
Great, thank you.
Thank you.
I had a question. Might be a little bit of a leading question, but I'm curious, do you find it challenging, or how do you deal with being on the CTRC where you're reviewing protocols from all different specialties and cancer malignancies, but your expertise as a breast surgeon, so how do you kind of reconcile that?
Yeah, no, I think it's a great question. Well, I definitely prefer when I get, there's often are protocols that come through that have something surgical about them. And so the person who assigns the protocols tends to push those more towards the surgeons who are on the committee, just because we're sort of, even if it's not general surgery, we're kind of aware of what goes on in the operating room and what the kind of issues around a surgical protocol might be. And then they definitely tend to shunt us, more like the solid tumor kind of thing. So I tend to get to review a lot of urology things, a lot of ENT kind of protocols, because, but please do not give me anything that involves, CAR T cells or lymphoma or things like that, because that would definitely be a bigger struggle for me.
I was thinking, although you could say, but sometimes not being the expert in a particular site, you can step back a little easier and just look at the research methodology.
I think that's absolutely true. And this, again, I'm full of ridiculous stories, but when you become a surgeon and then you become a general surgeon, if you want to become a fellow of the American College of Surgeons, you have to practice for a few years and then you put in this official application and then there's an interview. And when I came to the point of having the interview, I asked both Dr. Posner and at the time David Song, who was a plastic surgeon, like, well, what's it like? Like, what's this interview like? And they're like, oh, don't worry. It's like these two old guys and they're just going to like review your case log from the past year. And they'll ask you they're going to ask you like a professionalism question. They both told me the professionalism question they got asked. And I was like, okay, no big deal. So then when I go down to the college, because the college is in Chicago, for my day of my interview, and I am escorted into the room, and there are 10 middle-aged men, all men, sitting around a big table, and they've all got stacks of papers in front of them, and one of them clearly was the person who'd reviewed my case list and one who reviewed my CV and everything. And the one who reviewed my CV he was pretty harsh to me, and he was like you did, you took 7 years to do general surgery training because of the 2 years of research, and then you did a 3-year surgical oncology fellowship, and from what I can see, you're basically a breast surgeon. And I mean, I was like, you're ridiculous, but I kept the profanities out, and I said, all the training I did, it prepares me. You're exactly right, Dan, to be involved in things like the CTRC, to be able to, critically read protocols, to talk to my patients about what studies mean, and the results of studies, but also, do I think this is a reasonable study for them to think about, participating in? So all of those things, all those years for me, contributed to who I am and how I'm able to be a full participant, in both my patient's care and in, the university programs and the cancer program overall. So anyway, he accepted that answer and I became a fellow, but it got a little challenging for me for a few minutes.
Any other questions from the students? I have one other question. I guess I would ask, how have you seen the field of surgery change in general as far as gender balance and women going into surgery?
Yeah, I mean, there's no question that there's more and more women. And in fact, in our own general surgery program, the years kind of come and go, but in terms of the ups and downs of gender, but we have more and more female. And in fact, the incoming intern class is majority female. And when I graduated from UCSF, actually, I was the very first year. We had 9 chiefs a year at UCSF because we just covered a lot of different hospitals. But we had actually 6 women and 3 men graduate, and UCSF has always been a very strong program for women. And now there's the current chair there and the previous chair have been women. There are a huge number of women chairs of departments of surgery now that, for years and years, it was one. Chicago, a woman named Olga Jonason had been the chair of surgery at Stroger. And
I worked with her as a medical student.
Yeah, she was amazing. But she was it. She was like the poster child. And now there are innumerable. Stanford, Yale, UCSF, the Wisconsin. I mean, there are many programs now who have female chairs. So I think that it's to me, it's absolutely a thing. And obviously, doing breast, I'm kind of skewed, right? Because the vast majority, in fact, there was someone, a patient who I saw this week who somehow had a bad interaction at some point with some woman doctor at an outside hospital, and then was coming to U of C. And when she was told she was getting a woman surgeon at U of C, she's like, "Well, I want a man." And they said, "Sorry, there's no male breast surgeon." So and so then she asked around about me and got the thumbs up. So yeah, it's really wonderful. We have amazing female surgery residents in the program. So I think as a medical student, you guys, when you come through the surgery rotation, you'll see that there's the huge huge strength in the women in our program, and I really think that plays out across the whole field now.
There's a question from Ellen. Maybe let's make this last one, as we're almost at 5 o'clock. But Ellen said, what does the trial process look like for surgical oncology innovation? Like with removing fewer lymph nodes, how do surgeons go about managing the ethics of something that is normally so ingrained in protocols with such serious outcomes?
Yeah, no, that's great. So it's a really interesting story. You know, for the whole Sentinel node thing was taken extremely like methodologically. So in the 1990s, you know, when this Sentinel node idea first came up about for melanoma, and then people were like, well, that's interesting for melanoma, but this is going to be like practice changing for breast. But like the whole decade of the 1990s was done basically taking out the sentinel nodes, but then doing the complete dissection, right? So you could prove without a doubt that if the sentinel nodes were negative, that the rest of the nodes would be negative. And then there was actually a big, what's the word, like schism or controversy around this, because in the late 90s, as this became clear, the NSABP said, well, we have to do a big old randomized trial, right? Now that we prove that this, now we want to do a classic randomized trial. And then the father of the sentinel node for breast, Dr. Giuliano, who's a Pritzker graduate, U of C graduate, 1973. You guys could see his picture down in the hallway. And he was like, that's ridiculous, right? This is like, you don't do a randomized trial for something that's a well-proven technique. And so that's actually when the American College of Surgeons Oncology group got started as a separate trial mechanism to be able to ask more aggressive surgical questions. And now, of course, ACOSOG got, you know, incorporated along as part of the alliance. But all of these things have really carefully and surgeon-led, you know, these have been surgeon-led trials to really work through all these things. And so back to the robot question, you know, that now it's really it's not something that people are just gonna start doing. And one of the reasons, you know, people love to innovate, and you could say, well, it's just another way of doing a mastectomy, but there's a guy whose wife died after having a morcellization, you know, of her uterus, that her uterus was being taken out for fibroids, and it ended up that there was a sarcoma in the uterus, and it seeded, you know, her whole abdomen, and she went on to die. And so he's been a huge advocate about that things have to be, when it, you know, involves the potential of cancer, you know, spreading, that you have to be very methodologic about this. And so now the FDA is not letting, not giving approval for robotic mastectomies. It's being studied in a really structured way. And I will say, I actually went to Milan to watch the guy in Milan do some robotic mastectomies. And in the case that I watched, it was a prophylactic case. So there no known cancer. The patient had a negative MRI prior to the surgery. But it definitely raised some questions, like, you know, you're in this space, and of course there's a bunch of CO2 being, you know, shoved in there, and at one point the breast kind of was being like flipped around, almost like flipping a hamburger, you know, on a grill in the space, and it sort of crosses your mind, like, if there's cancer in that breast, you know, and you don't, and it's at a margin, it's everywhere right now, you know, it's everywhere in that cavity. And so it's going to be really carefully studied. So that's a really great question. So we sometimes we're very careful on our own regards, and sometimes the FDA makes us be really careful, and that's going to be the case with robotics.
Yeah, I think I just think it gets a kind of more fundamental clinical trial question of how do you do therapy de-escalation trials. It's very easy to convince yourself more is going to be better, but how do you step back what's been effective so far, you know?
Yeah.
So, all right, well, if there aren't any other questions, that was a wonderful talk. Thank you so much, Dr. Jaskowiak.